moderator will be Sachin Tapasvi, and our faculty for this session is Christian Clay, Rick Kundra, Deepak Chaudhary, Dr. Arumugam, and Nagraj Shetty.
So I think we'll try and discuss some principles of revision ACL, and I thought that I will just include infected ACLs, ACL reconstructions in the same breath as well, so that we can discuss them in the same aspect. So Rick, when you see a patient who's got a failed ACL, and would ruling out infection be the first thing that you go to? Because that seems to be one of the main criteria that you want to look after.
It's not top of my mind, no, unless, of course, patient has features of concern.
Yes.
Such as pyrexia, persistent effusion, redness, warmth, pain that's on mobilization. I mean, the incidence of infection in primary ACL is something like 0.3% for primary ACL. So it wouldn't be top of my list, but obviously with any revision procedure, infection should be ruled out. But I would rule that out on clinical grounds.
Correct. So we saw that in most of the cases today, a lot of surgeons were pre-soaking the graft. Nagraj, is your practice as well?
Always.
Pre-soak your graft?
Since the report came.
On this side, on my left side, everybody pre-soaks their graft?
Always soak in vancomycin.
So I think it could probably be a good practice that we pre-soak our grafts with vancomycin solution, because that really helps. And the next question to you, Nagraj, is that what sort of concentration and what choice of antibiotic do you use when you pre-soak your graft?
All the literature has supported cefazolin, but it is not available in our country. So cefuroxime is the next best for Staph aureus. So
Cefuroxime? Okay.
Supacef is what the brand name is.
That's interesting. How about you, Rick?
Vancomycin.
Vancomycin. This side?
Sorry, you were asking for soakage of the graft. Obviously, yes. Vancomycin. I thought you were talking about prophylactic antibiotic.
No. We're talking about
vancomycin, 500 milligrams.
Vancomycin. Yes, so I think vancomycin is probably the go-to drug of choice when we're looking at pre-soaking the graft, when we're doing any of these primary procedures, and obviously when you're doing a revision, that is what you would want to do as well, because pre-soaking will convert your graft from a source of infection to an antibiotic delivery system, to be very honest. And vancomycin is preferred for all the reasons. It's water soluble, it's heat stable, and it's got low resistance against gram-positive. So that seems to be the graft of choice. The way we normally would do it is to take about 500 milligrams of vancomycin in 100 ml of normal saline. And then when you soak your single gauze piece with the same, it soaks about 7 ml in one gauze piece, so it gives you around 35 milligrams of vancomycin, which is less toxic to the cartilage than if you compare it with cefazolin, gentamicin, or the cefuroxime that we have here. So let's come to this particular example here, Dr. Chaudhary. So when we have someone who comes maybe about 2 or 3 weeks following an ACL, which is obviously not done by you but by someone else, what is your strategy for graft salvage? So my question is that when do you decide preoperatively, not intraoperatively, preoperatively, that you will save this gentleman's ACL or you will get rid of it?
So the person has come with an infection.
Yes.
So if there is any sign of infection, I think my first thing will be to admit the patient, administer him IV antibiotic, just observe for 1 or 2 days. Otherwise, I'll be quite aggressive in doing an thorough arthroscopic lavage and then see the condition of the graft. And many times we have been able to, in early cases, just by a clean out and synovectomy, we have been able to save the graft.
Aru, your recommendations, when do we salvage a graft? I mean, what is your strategy for dealing with an infected ACL?
Once when 3 weeks old comes in, I will do some.
Let's say 2 weeks. Okay, he's 2 weeks down the track. Yeah.
I'll do some blood investigation.
Yeah.
White cell count, CRP. If there's any effusion, anything, I aspirate and send for the analysis. And if it is not very acute or bad, I try to salvage it. Otherwise, I'll go in immediately to do arthroscopic lavage and see the correlate with the clinical results of this test, and then decide whether to save the graft or complete debridement.
Kristen, what's the German take on salvaging the graft and getting rid of it?
Well, actually, it's arthroscopic debridement, and doesn't work. It's sorry. It's arthroscopic debridement and lavage that we perform, obviously. But I would say you cannot really preoperatively assess that. So you have a plan, obviously, that you try to hit, but whether it really fulfills the surgery will show. You look inside of the joint, and if the Gechter classification just shows an infection which is obviously too progressed, then even in a short duration time, I would probably say I remove the graft.
Okay.
So there is plenty of aggressive infections that you cannot really well treat. And mostly it's obviously the tunnel, which is the source. So you can debride whatever you want, but it's in the depth and it'll come back.
Excellent. So I think, we've sorted out
Can I add a point?
Yes, please, Nagaraj.
Something important, so I thought I'll mention this. I think we need to look at the organism, the virulence of it, the fact that whether it is presented before the 2 to 3 weeks time, before the Sharpie's fibers have formed, or later. Atypical mycobacteria, methicillin-resistant Staph aureus, whether you've got the organism or no, will also determine your decision whether you can save the graft. So if you've got the bug, if you've got the sensitive antibiotics, you might take a chance with graft preservation. Aggressive bug, you need to go ahead and take out everything out.
Yeah. Completely agree with you. Yeah. So I think all the delegates, if you have any questions, you can absolutely go ahead and shoot your questions. Well, yes, microphone 5. Microphone 5, somebody.
Hello.
Yes? Yeah.
Yes. Whether as in infected ACL, whether your decision is prior to scopy or it is intra-op decision to sacrifice the graft or save the graft.
Okay, Rick, you want to take that one? The decision to salvage the graft, is it preoperative, intraoperative? I come to you with an infected ACL. What sort of discussion will you have with me? Are you going to tell me that you're going to try and save my ACL, or are you going to tell me that this needs to go? I'm 2 weeks down the track. I'm not 3 months, but 2 weeks.
So it's relatively acute presentation.
Yes.
So I would obviously consent the patient for both. My aim is always to try and retain the graft, but at times we have to sacrifice the graft. So the things that would be pointing more towards sacrificing the graft, usually these decisions are made intraoperatively in the acute situation. So if there's loss of tension of the ACL graft at probing, that would be a significant indication to me to sacrifice that graft because it's non-functional.
Yeah.
If there's prolonged exudate after debridement, because obviously as treatment of any infection surgery, we need to reduce the bacterial load. So if I can't do that, if there's persistence of prolonged exudate throughout the graft, that's going.
Perfect. Any questions on infection? Yes, microphone 3. Microphone 3. Yes, yeah, go ahead.
Have you ever converted arthroscopic debridement into open arthrotomy debridement?
Good question. Arumugam, how often have you changed from a procedure that was arthroscopic and made it into an open procedure?
Never done.
Never. Deepak sir?
Never.
Christian?
Never.
Never?
I have done it quite a few times.
Quite a few. Why quite a few?
Especially if it's an atypical mycobacteria, if it's an organism that is presented with...
No, but you've gone in with the plan of doing an arthroscopy, but now you've made it open. Why?
No, the primary plan was to go ahead open because we saw that the organism was virulent.
So you've not changed intraoperatively?
No, because all this planning has to be done preoperatively and the patient has to be counseled that you are going to be receiving an arthrotomy.
Okay. So I think most of the panel feel that, it's a preoperative decision whether to do it arthroscopically or open. Okay, 4.
So any experience of early tibial side screw infection along with debridement, if we put any antibiotic stimulant beads over that place for some time, because that helps in giving a local antibiotic concentration.
Rick, I'll ask you to answer this question. So there's discharge coming from the tibial wound site at around 2 weeks, 3 weeks?
Less than
3 weeks. The knee is quiet, but the tibial wound is leaking. Do you think it's infected? Do you think it's just a tissue reaction to the screw? Will you go ahead, take out the screw? Will you wait? If you take out the screw, are you going to pack antibiotic beads inside? It's a difficult scenario, but it's not so uncommon.
No, it has occurred. It does occur. Usually that sort of early discharge, that serous discharge, tends to occur if we don't get good layered soft tissue closure on the tibial wound.
Okay.
Because obviously there's extravasation of the fluid.
Yes.
But obviously other markers for suspected infection we would consider. So obviously blood parameters we would do.
Yeah.
We would see clinically you said the knee is quiet. So there's no major effusion, good range of motion, no change acutely for the patient in that respect. So I would try and be a little conservative at this early stage.
So be a bit conservative. I think that's any difference of opinion, because you get this oddball curveball that comes once in a while when the knee is quiet, but there's some leaking tibial wound, and I completely am with you. So I'll be a bit conservative in this aspect. I'll try and take some deep cultures, and then if it grows anything, then obviously the writing is on the wall. You need to go ahead and debride the tibial site because you risk any form of osteolysis, but otherwise that is what we would do. Yeah, is there a question at microphone 5? Yes, 5?
Sir, I had a similar experience. At 3 weeks, there was infection at the screw side.
Yes.
And we removed the screw. And we removed the tissue also, the antibond, everything.
Yeah.
Sent for culture. It turned out to be MRSA.
There you go.
The patient wanted to go to the higher center.
Okay.
Then the patient went to Sancheti.
Okay. Parag, question for you. Yes.
Yeah. There they debrided, we had debrided the joint also, and but after 15 days the infection kept on recurring.
Correct.
So they went to Sancheti, they debrided the whole proximal, they turned out to be a proximal tibial osteomyelitis.
Correct.
And they put a cement spacer.
Yes.
But it continued to this, and it was further referred to Mumbai. And it, in the deep cultures and the long cultures, they turned out to be mucor.
Yeah, so I think this is one of the important points is that, sometimes if you have very bad organisms, as what Nagaraj was alluding to, then you need more radical procedures. So thank you so much for that. So I think whenever we're working up an aseptic failed ACL, a couple of things that I use in my planning. I always use a AP scanogram film. I always use a lateral
Sachin, I think there's a question at the mic 3.
Stance view. I'll come back to you. I use a lateral monopedal stance view. I use stress X-rays if I have suspicion for any medial or lateral sided injuries. Of course, we use MR scans. We saw MR scans and CT scans as well. So, Christian, I mean, anything different that you use in your practice besides the 5 things that I've listed out for an aseptic failed ACL?
Yeah, well, actually, what I'm doing is I don't apply for stress X-rays. I perform a Rosenberg view, but that's the only difference that we have. I guess it's quite a standard setup that you're having here.
Yeah, Arumugam, anything different?
No.
Yeah, so I think fairly standard. So, Dr. Chaudhary, would you agree that if you're looking at a failed ACL, then all of these 5 different imaging modalities are essential to understand the whole picture, or you feel that if you have an MRI, it's okay not to do a CT scan? If you don't have a CT, it's okay to not do an MR?
So most important is that if you have a failed ACL, you have to try to understand the cause.
Correct.
And all these things like the CT, MRI, the most common cause we all know is non-anatomical placement of the tunnels.
True.
So to that effect, this CT and MRI are good indicators, and another most important cause is failure to address the secondary stabilizers.
Absolutely.
So with that respect, the stress X-rays we find very, very useful in our practice.
Christian, you want to make a point?
Yeah, what you have done here was a lateral long leg standing film. I think that's great. I don't perform that routinely, so what I do is a long tibial view, obviously. So that is what I want to know. I guess I know what you wanted to stress here.
Yep. Okay. Let's come to tunnels. So when we're looking at tunnels, I'm sorry, there's a question from microphone number 3. I mean, I just was on that point, so I forgot. Yes, please. Are microphone? Yes? Yeah.
That question was regarding infection.
Okay, so we'll go back to infection, yes.
So if harvested graft gets dropped on the floor, what's the current guidelines?
Never has happened to me. Anyone on the panel has had a graft dropped on the floor?
Well, we've had that.
Okay, Nagaraj is going to ask that question. Did you drop your graft or someone else's graft?
It was my graft.
My graft, okay, lovely. What did you do?
And I changed the graft option completely. There are ways to salvage it, but I want to sleep well, so I shifted over to a different graft source.
Rick, you're smiling. Please go on. What's your anecdotal experience?
No, I was just laughing at dropping someone else's graft, but no, I would do the serial dilution.
Yes, Deepak sir.
About 10 years back, when I was in Sports Injury Center, there was a tennis player, national level tennis player.
Okay.
And unfortunately, her graft dropped on the floor.
Okay.
And we were quite worried, but we, with copious amount of saline, antibiotic wash, after doing all this for close to half an hour, we again reinserted, and she again went back to her active sports, and even we had a 5-year follow-up. So
excellent. So there are reports of using a triple antibiotic solution which includes polymyxin B and tobramycin and something else. And they have shown that is to be salvaged. But this is not something that we see very often, so it are case reports. Yes, Christian?
Actually, there is something that is called staged lavage. So what you do is you 7 times in a new solution actually lavage the graft for 3 minutes. So you lavage it down all the time. So actually the best salvage of a potential infection to clean something is still washing it. This is why we wash out wounds. And actually in Hanover, this is a little anecdote, in Hanover Medical Center, when transplantation really started, so back 30 years ago, a kidney fell down.
Oh dear.
It was really, so the nurse that let it drop actually stopped working immediately. So she left hospital and really got mad later on, but anyhow, it really dropped and it fell like bomb, bomb, bomb. So, and everyone was looking at that kidney, but what they've done actually was a staged lavage, and you have to do that, and there was no infection problem.
And the patient is passing urine, correct?
No, obviously.
I think the surgeon first peed in her pants, right? And then
I mean, what a disaster situation.
Yeah. Yes.
Follow-up point for this.
Yeah.
Can we use pulse lavage?
Yeah, I guess you could use pulse lavage to wash out the graft. Yeah.
Yeah.
Yeah, but then follow his technique 7 times for 3 minutes.
Okay.
Okay. Yeah. No more questions. We'll move on to the question. Yeah, 3. That mic is getting switched off. Can someone have a look? What's happening to that?
Hello.
Yeah.
We are at about 3 months post debridement. We've removed the graft. We've given 6 weeks, 4 weeks of IV antibiotics. Now the patient is visiting us at about 3 months, 4 months. Knee is no effusion, no swelling, range is good. What would be the ideal time to go for the revision ACL?
Okay. So Rick, I'll ask you to take this question. You've planned a 2-stage procedure. So you've taken out the graft, you've cleaned the tunnels, you've taken out all the hardware. The knee is now quiet, correct? And what is the ideal time for you to go in and redo the patient's ACL?
This following infection?
Yeah, it's from an infection point of view.
So the key thing is the patient needs to have a prolonged period of antibiotics. So at least 6 weeks of IV or oral antibiotics or a combination. What we would do is we would then follow the blood parameters. We would need normalization of CRP and white cell count initially before we would consider anything further.
So 3 to 4 months is a good time.
Yeah, 3 to 4 months average.
Okay, thank you.
Would someone in the panel would wait for 6 months post the debridement, 9 months, or would prefer to go in early if the knee is quiet?
So if it's just like doing a 2-stage knee replacement. Once you find that you're off antibiotics and your inflammatory markers are down, then we can go ahead. Okay, we'll just take all the other topics of the revision panel. When we look at tunnels, we look at hardware problems, we look at location of the tunnels, and we're going to be looking at tunnel dilatation. So these are the 3 main things that we need to look out for. And obviously, we do have issues with removal of implants. So when you have something like this, as you would rightly observe, this is endo button that is floating in the joint. So a button floating in the joint probably will pose a bit of a challenge for removal of a foreign body. This is an intraosseous diploid button which I had to once tackle, and this is probably one of the more commoner type of implant failures that we see when these closed loop buttons had to be manually prepared using some Mercilin tape, where sometimes you would encounter that these were free floating in the joint. You can have free floating screws as well. So the problem really comes when you have properly, you have an intraosseous screw, a metal screw. So any specific tricks, Dr. Chaudhary, to try and get rid of, stubborn implants?
No, these hardwares, we encounter a lot of patients for revision surgery unless they are interfering in the way of your tunnels or...
just leave them.
Just leave them.
So Aru, let's say you had to do a ACL revision and you have a peak screw. Will you drill through it or what would be your choice?
Depends on where the location.
So it's
the wrong location,
it's going to cause conflict. So it's not a biodegradable screw. It's not PLLA or PGLA. It's a peak screw. So it's not going to, it's going to be sitting there.
No, if it is non-anatomical position, I won't touch it.
Okay.
Create anatomical new tunnel and go ahead.
So I think if you look at tunnels, something like this, where the tunnel is completely wrong, this is a transtibial femoral tunnel. It's probably the best you can deserve. You just ignore the old tunnel and drill a new tunnel. If it's a completely correct tunnel, you just ignore it and drill a larger sized, over drill the hole and use a larger diameter graft. The problem comes when you have partial anatomic tunnels. So if you have a tunnel which is partially correct, question to you, Arumugam, is that what do you do? Do you do a two-stage procedure or do you do something like this where you fill that hole with a screw or a bone graft and do a single stage?
Yeah, luckily I do more of BTB, so I can take a bigger BTB.
So let's say the tunnel dilatation, it's a partially incorrect tunnel. The previous tunnel is about 10 millimeters. So what are you going to do now?
And if 10 means, then I have to two-stage.
Two-stage. Christian?
I would fill that tunnel up. I would fill the tunnel up.
So you prefer a two-stage?
Yeah.
I would do a one stage. I would change the angle of drilling and maybe I will fill the tunnel with a bio screw.
That's an excellent point. Two-stage, one stage? Rick?
I would try and do it as a single stage because using outside-in drilling, we can affect the external aperture and trajectory.
Nagaraj?
Filling of the tunnel, I reserved on the tibial side, femoral side, outside-in drilling, change the trajectory.
I think that's a good point. I think that becomes my go-to technique as well, where you change the trajectory and do something of an outside-in drilling. We saw a good example of how to do outside-in drilling, and that really makes life a lot more simpler. So you can, potentially avoid this overlap, which you otherwise might encounter when you were transportal drilling. Let's look at from the tibial side now, and Rick, this is where your tunnel should be, or this is where the ideal position of the tunnel is, the one in the blue, but you have a very anteriorly placed tunnel, okay? So this anterior tunnel, like what we saw in the live demo which Matthew was doing today morning, what is your strategy? So this is an example of a tunnel that went too far anterior and too far medial, and what is your strategy for such abnormally dilated tibial tunnels?
So I have a lower instance, a lower level for doing a two-stage for a tibial side.
So what's the cutoff? I mean, what diameter of tibial dilatation would you say that, okay, now this is a two-stage? When you start thinking of a two-stage?
So it's not just the diameter that I would go on, it's obviously the location. So these partial anatomic dilatation are around, say, 12 millimeters or more are the ones that I would be erring more for two-stage.
So I think this is a very good point. So it all depends not just upon the millimeters of dilatation, but the location as well. And if you have something which can be salvaged, then you can enlarge the same tunnel and, you can, where am I gone now? Yeah, you can enlarge the same tunnel and you can put a screw in the front which can help salvage it. So the anterior tibial tunnels are a bit easy to salvage. The problem happens when you have a partially incorrect posteriorly placed tibial tunnel. So the blue is where you should be, the green is what has been made. And if you have a very large dilatation, something like this, so the line that we want to draw is what is called as the Amos line, which starts from the front of your tibia to the posterior aspect, and your tibial tunnel should be around the 42 to 44 percentile from anterior to posterior. And if you have a very large dilatation with a posteriorly placed tibial tunnel, then you have to be careful because these are probably the more notorious ones, because if you place your screw posteriorly, it's not a very good idea, because what happens is that a posteriorly placed graft is more inferior from a biomechanical standpoint of view. And if you have a long posterior screw tip, it leads to graft abrasion. So be careful of tunnels which are incorrectly placed on the posterior aspect. Aru, any difference of opinion, any different strategy? Because what I've shown is probably what I use. Anything different?
Standard one.
Yeah. Okay, graft options. Now, allograft is a big challenge in our country. Christian, I believe in Germany you don't get allografts, am I right?
Well, only for certain occasions and on special requests, so let's say no.
Okay, so for your revision ACL, what do you use? Do you use, do you use the same side autograft, or do you go to the opposite side? Well, I mean, what's your preference?
Actually, my primary revision graft is a quad tendon.
Yeah.
Obviously, if you're a quad tendon primary guy, you could take the quad tendon from the contralateral side.
Yeah.
And we quite commonly do that. I mean, there is patients having had like maybe a multiple ligament injury, which was treated. Then you need to go to the contralateral side anyhow. So me myself, I had 2 ACL replacements. If they want to do my ACLs, they have to choose whatever they want. So anyhow, it's the way it is.
Mostly the same limb autograft. The hamstring may take a BTB, or I taken a BTB or something. I also use peroneus longus more often. So,
Dr. Chaudhary, you said that you're always using soft tissue. You don't use BTB in the morning session. So you have a failed double bundle hamstrings. What are you going to use?
Actually, we have some instances where some of our own cases which have failed.
No, let's say my double bundle failed. Okay, I have done that and I've come to you.
I would still do a double bundle because we always feel that the volume that double bundle generates is much more. 8 for the AM and 6, so around 14. So in a revision situation, more the volume, the better it is. So I would counsel my patient, and my first choice will be the contralateral hamstring.
Contralateral hamstrings. Would you do a soft tissue graft replaced with a soft tissue revision? Or if you have a soft tissue graft failure, will you then use a bone plug?
So a couple of preoperative analysis factors on the patient's anatomy becomes important. If the patient has got hyperextension, patient has got ligament laxity, patient has got some tunnel dilatation in one of the components,
yes,
I would use a versatile graft like quad tendon bone.
Okay.
You can turn the bone component on one of the ends, and I'm secure that the bone component is going to take care of the laxity part also. And obviously add I think you'll come to it, but add a LET procedure also.
Rick, graft fixation. So for primary ACLs, we are happy with one fixation on the tibia, one on the femur. When you go to a revision situation, you're doing a single stage, you have some tunnel dilatation. Do you add a double fixation for security or not?
Yes, I do it on both sides. So I would even use a button extender on the femoral side. And then on the tibial side, I will always secondary fix.
Double fixation on the tibia and a more robust fixation on the femur.
Yeah.
Double? Single?
Always double in a
both sides?
Preferably both sides.
Okay.
With the newer cortical fixation, you just have the option of making sure you tie a knot so that there is no elongation of the
knot over the button.
Over the button.
Single or double?
It depends. If we have made a completely new tunnels, we don't add any. But if we are using the old tunnels and the bone quality is not that good, on the femoral side, we add the bio screws.
Okay. So again, double fixation. Aperture plus suspensory. Aru?
It depends. Mostly I do only single fixation. Is not
even on the tibia?
Tibia sometimes more often do
supplement
backup.
Christian?
Suspension, and I abandoned my post fixation. So I usually tied it over screws, but I abandoned that.
Okay, a quick yes or no on extra-articular reconstruction. I mean lateral ITB plasty. Yes or no? Christian, yes.
Not always.
Not always. Not always for revision. Never. Christian, yes, no.
You mean, extra? Yeah, of course. Of course.
ITB tenodesis.
Yeah, Lemaire that we've seen today.
Lemaire.
Yes?
Lemaire always.
Okay. So 2 yes, 1 no, 3 yes, 1 no, 1 maybe. Slope correction, Christian. Okay. Indication for slope correction. When do you correct tibial slope in a revision situation? We'll be seeing it live in the next surgery, but can you give us some tips as to when would you correct the slope when you have a failed ACL?
Yeah, it's hard to give a recommendation on the definite degree. So, but obviously there is some range where you would say this becomes pathological, and then you have to make an individual assessment, I guess. So, but
give me a number after which I should start getting worried
I
about
wanted
it.
to avoid that, obviously, but I would say 15 is surely
15.
something that you would go for. But the question is that a primary case? Is that a revision?
It's a revision. We're talking about
revisions. Okay.
Yeah.
So in a revision case, obviously, I would rather say I go lower than that. So even 12 would be something
12.
for me that I would.
Yeah. If you are to perform a varus correction, Christian, would you do a medial open wedge and decrease the slope, or would you do a lateral closing wedge tibial osteotomy, which anyways decreases the slope?
So I would probably tackle it from medially, as that is my common practice. In open wedges, you can deal with slope changes, and you can do that intentionally, obviously. So if you have a varus deformity on top, I would do it from the medial side.